Great. All right, everyone. Good morning, good afternoon, and good evening to everyone. My name is Megan Rybarczyk. I am the Global Emergency Medicine Fellowship Director here at the University of Pennsylvania in Philadelphia in the United States. We have a small cohort of folks here in person in Philadelphia that will be running this case competition, and then we have several people online as well too, and then all of you joining us from across the world. So thank you very much for your time today. We are very excited to be doing this second installment of our Global EM Case Competition. This is in conjunction with the Department of Emergency Medicine here at the University of Pennsylvania, as well as the Center for Global Health. So thank you so much to those of us supporting us. A huge thank you to Alejo, who has been the biggest coordinator of this program today. And we will go ahead and get started with our keynote. So it is my distinct pleasure to welcome Dr. Saima Ali as our keynote speaker today. She is head of emergency medicine, the adult section at the Indus University Hospital in Karachi, and she has been in that position since 2017. She is also the former EM residency program director there. She is a clinician educator with a PhD in health professions education from the Massachusetts General Institute of Health Professions, which is affiliated with Harvard University in the United States. And she has a keen interest in contextual research. She is a published author of many papers in national and international peer-reviewed journals and is research faculty at the College of Physicians and Surgeons in Pakistan. Her research focuses on advocacy for patients' rights, improving healthcare workers' well-being, and prevention of burnout. Dr. Ali has developed interprofessional educational programs to build capacity among physicians and nurses in Pakistan and published findings to support practice improvement. She is a dear colleague and friend, and we are so excited to have her as our keynote today. I could go on and on for many hours talking about her amazing credentials, but I will turn it over to her to get started with our keynote address today. So Dr. Ali, over to you, and thank you so much for joining us.
Thank you so much, Dr. Rybarczyk, for the very, very kind introduction. And I can assure you at times, when Dr. Megan is saying nice things about you, you sort of feel like looking over your shoulder and say, are you really talking about me? So it's an honor and a privilege to be here amongst all of you. It's very exciting to be on a platform where young researchers get to show their unique cases from across the globe. And I am looking forward to hearing all your hard work being brought forth by this platform. A big shout out to the Department of Emergency Medicine at UPenn and all the faculty, residents, and fellows who are doing an amazing job. Thank you so much for having me. So I will be starting my presentation. And when we were sort of discussing ideas, we wanted to talk about so many things because there's so many things that can be discussed. And because we are all different, yet we're all the same. And that sort of stuck in my head. And that is something that I would like to share with all of you. This is by no means an intellectual conversation. This is just an exchange of ideas. Please feel free to stop me at any time and do let me know if my slides create havoc, which happens, just always happen at various hours. So the title of my talk is talking about resilience. How do we get there? And using capacity, context, and the emergency departments as how we see them together as a single community. And hoping to achieve this from knowledge transfer to knowledge exchange. As Dr. Megan has told you, I am working as the head of the department of one of the busiest emergencies in Pakistan, which is situated in South Asia. We are bordering with India, Iran, Afghanistan, and the Arabian Sea. We are one of the worst regions in the globe due to climate change, and a lot is happening in Pakistan geopolitically all the time. So, most news, albeit at times not in a very good way, but there are amazing things happening in Pakistan. So, As I said, I'm super excited in this room because talk about emergency departments as resilient healthcare systems. We all know that emergency, every emergency is the face of the hospital, and every emergency reveals the truth about the healthcare system of that particular country, right? So if you have primary care that is not working, if you have tertiary care which is oversaturated, the reflection is seen the best in every emergency, and people from across the globe are gathered on this platform. So this is actually a prototype for a global learning community, local cases that will be presented. Please do not think of them as a small contribution. They are a system level of your disease burden, of the things that you see usually, of the things that you see unusually, and the care that is provided amongst resource constrained, overburdened uh, emergency departments, which across the globe is amazing. Sustainability and the resilience and the grit shown by our community by far. At the risk of sounding a little pompous, I would say that it is the best among all medical specialties. And joining together on this virtual space has reduced those barriers where we can actually come together and share ideas, talk about our common challenges, and perhaps find common solutions. So, as I said earlier, while developing this presentation, the first thing that struck and came to my head was that we are all different, yet we're all the same, because emergency presentations may differ by epidemiology. Infrastructure might be different, the workforce that is present, the kind of conflicts that we are exposed to, the logistic challenges that we face, the finances, we have them, we don't have them, it might be different. But the underlying human encounter for the providers as well as for the people who are coming to the emergency department is always the same. We are faced with fear, we're faced with urgency, uncertainty. We have family presence, we have imperfect information with limited time, a lot of moral pressure that we deal with on a daily basis. So, resilience is not only concerned with surge capacity. And a disclaimer, a lot of the pictures that you will see are from our own department, and those that aren't are credited with the appropriate citations. So, when we talk about resilience, people think that resilience is shown when we are faced with disasters, when we are faced with conflicts, when we are faced with wars, when we are faced with uh, things that are more than what we can chew. But for emergency departments, I think it's every day. It's not only about surge capacity. It includes the continuity of care. It includes our coordination, rapid recognition, our rate of referral, the data that we are producing, and the data we are able to capture, the governance structure that we have or do not have, and the preparedness of all the departments in our country, in our region, in across the globe, for all the man-made and the natural disasters that are so common in these tumultuous times. So emergency care spans across scenes. It starts from the scene, then we have the transport, then we have the facility, and then we have the inpatient care. But uh, how do we learn about it? How do we understand it? How do we understand how an emergency works? And the fortunate thing is that we are given the clinical knowledge when we are going through our med school and going through our residency. We all go through our books, our podcasts, our, you know, burn the midnight oil and pass all our exams. And that's the clinical aspect. But how is it that an emergency actually functions? So emergencies are much more than clinical knowledge. Uh, because education that is happening every day. It only matters if it is impacting or making a change while working in a shift. So a simple case can become a protocol can become a quality initiative, and a quality initiative can lead to scholarship. Um, and the best of it happens when we are learning together. So I'm very fond of theoretical frameworks. I try to find out why is it that we do what we do, and what's the reason behind it. And educational theorists have come up with the theory of social constructivism, and they say that meaning is built through interaction. When we learn together, when we have situated learning, the learning becomes inseparable from our authentic practice, which is not only retained more, but you develop mental maps that result in rapid clinical provision. And health professions education literature confirms the value of social learning theories. And the best example, again, of social learning between different professionals, between different disciplines, between different specialties is the emergency. So, but when we're talking about knowledge, gaining knowledge in the emergency, and when we're talking about collaborations, and when we're especially talking about HIC and LMIC collaborations, we need to understand that there is a difference between knowledge transfer and knowledge exchange. So when we're talking about knowledge transfer, we think about a one-way traffic. It is coming from the HIC towards the LMIC, and at times it is not very context. Whereas when you're talking about knowledge exchange, and again, we're all here for that same purpose today, talking about a bidirectional, my listeners at times, but you can read the word, adaptive and co-owned exchange of knowledge. And uh, all the same, the emphasis is always about learning with context. So what might work in a particular environment or a particular setting might not be the best solution for another setting. As I say to my residents at times, that when you're reading protocols, when you're reading guidelines, please do understand that these guidelines were written by somebody who did not look like you, did not have your anatomy, did not have your physiology, did not have the same socio-demographic, um, environmental circumstances as you. So take it with a pinch of salt, understand the logic of it, but apply it contextually. And that is where emergency needs to learn that we need to stop asking questions like, how do we export best practices? And start asking questions like, how do we co-produce usable practice across different realities? So my reality is certainly different from the reality of the Department of Emergency Medicine at at the University of Pennsylvania. It's different from somebody working in Canada, which is certainly different from somebody who's from Vietnam or from Ethiopia or from any other part of the world, be it the north, the south, the east, or the west. And we need to come up with solutions that are generalizable, that can be used by everybody across different realities. But that would mean modification and understanding and contextualizing the same solutions. So, when we're talking about capacity building in the emergency, it does not end in the classroom. We all have our protected teaching time. We understand knowledge, we gain psychomotor skills. But for us, capacity building changes how care is perceived and provided. So, just as an example, picture a crowded ED and can be in any country, in any region at shift change. A patient with infection related shock arrives late, and this patient has come to you after multiple delays, multiple negative social determinants of health are present, and family members are very anxious and exhausted. And when you're talking about such patients, I think all of us have seen them. So the immediate lesson is always clinical. You need to stabilize the patient. You need to start with your A, B, C, D, and E. But the deeper lesson that overarches the A, the B, the C, the D, and the E is a system level uh, question which needs to be answered. Questions like who recognized the deterioration, how quickly did the triage work, did the team share a language of escalation, and were the protocols usable? So when we're talking about emergency department, you have a lot of um, things that we do. We have our case presentations, we have our handovers, we have our debriefs, ward rounds, resuscitation, and protocols, which are often perceived as interruptions to our education, which is obviously we are not sitting in a classroom when we're doing that, but they are actually the basic education that we get through our interaction, through participation, and through practice of taking care of our patients, and also of each other, our team, and ourselves. So, when we talk about shared learning, we talk about communities of practice, and we want to understand how groups can become the champions of change. So, we have communities of practice, and these communities of practice take an example of an emergency department working across, you know, um, for us, it's we have a footprint across the whole country. So my emergency department works as the head office for emergency departments that are situated in other cities. So we first of all create a community of practice within our own country, within our own region. And this community of practice creates a shared language, it creates a shared identity, and it identifies the change that it's seeking to have. These people need to be on the same page, need to identify the same problems, need to have a sense of identity, and then they become drivers of change that they want to attain as a group. And the role of adult learners is that these people do it through education. So adult learners need to unlearn a lot of things, and then they need to relearn, and they respond best when the problem and their solutions are relevant, they are given autonomy, and the design that is given is implementable and sustainable. And interprofessional learning, having multiple stakeholders on the same page, results in strengthening the system function. It just not only adds to the knowledge, but it results in solutions that are sustainable with all the stakeholders championing and rooting for them. And this collaboration is not an educational luxury. It is part of how the workforce is built for better care. So, talking about collaboration between HIC and LMIC, the one of the things that COVID did was it normalized blended learning. It normalized online education, and having a blended modular educational structure which respects local reality can help in capacity building, which can be really vigorous without being dependent on travel heavy or higher bandwidth. And we have all worked collaboratively towards that. We've been working extensively with the University of Pennsylvania, with Dr. Rybarczyk. We have worked with our colleagues at the Emory University in Atlanta, Georgia. We've also worked with colleagues from Canada, and we found that all these solutions do not require a lot of finances, but a lot of innovation. Uh, what are the what are the benefits of mutual learning between LMIC and HIC? Well, the LMIC participants gain visibility, they develop friendships, they gain peers, and they find out what scholarly pathways that might not have been that clear to them at the beginning. For the HIC participants, they gain an insight into cost effective, adaptable, high value ideas. And the questions that they ask become sharper. And we're going to be asking a lot of questions in this presentation as well. And the holistic change that we see is that the communities of practice at both LMIC and HIC can move from sharing to translation and ultimately to spread of knowledge. But let's be honest, there are multiple barriers. He needs to address the elephant in the room, and this can be in the form of power asymmetry. We have seen, and we all know about extractive partnerships where the LMIC partners are do not get their due share of the scholarly work of they are just mentioned in passing as an acknowledgement, and uh, there is there's lack of equity as far as the research or as far as the educational contribution and acknowledgements go. There are prestige hierarchies. There is definitely the barrier of a language barrier. People work at different bandwidths. Funding again is a major obstacle in attainment of equitable partnerships. There are travel restrictions. We might start a program, but we are not able to evaluate the impact of the program properly. So, starting a program, be it an educational program, be it a service provision program, be it any kind of scholarly work, there is no evaluation. You will not know how the program works, how the program has worked, and the results that it has produced. Uh, the sustainability planning is not very well thought of from the beginning. So you start something and then you have to leave it midway because you run out of funds or you run out of people who work your support. There is no clear governance. And obviously, we are all humans. There's the factor of burnout. If things are not equitably distributed, if somebody is doing all the work and the other person is taking all the credit, then there is moral burnout. There is physical burnout due to sheer hard work. And all of these things contribute negatively towards collaborations, towards learning, towards creating a model where everybody is learning from each other and growing together. So, there a lot is said about decolonizing emergency medicine, but what are the real points that are needed in practice? So the agenda needs to be very clear right from the get-go. And these are just some of the things that I thought of because of the time constraints. I can go on and on and on about, what are the things that are needed. But these five things struck out. So the agenda needs to be very clear. What are the objectives? What is the research question? What is it that we're actually aiming to do? And what are the perceptions of both the stakeholders, somebody from HIC working with somebody from LMIC? Everybody needs to be very crisp and clear about the agenda. There should be no ambiguity. Budget needs to be set from the get-go. You do not want to overspend, but you certainly do not want to underspend. Have you sort of all the avenues that are required to generate the amount of money that is needed to run a program and ensure its sustainability across years? What is going to happen to the data that is produced as a result of that intervention, be it an educational intervention or a service related intervention? Who's going to be the custodian of that data? Who's going to be producing scholarly work out of that data? Who is going to safeguard the patients? Who's going to safeguard the learners if it's an educational study? What are the checks and the checks that are in place to safeguard all the data that is generated through any intervention? Coming on to scholarly work, who gets to be the first author, who's the second author, who's the third author, who's the senior author? And all of these things need to be decided right at the beginning rather than midway or towards the end. Keep things clear and as clear as possible so that everybody contributes according to what they desire to have. The last thing, which is the most important, is what is the benefit of doing this particular intervention? What is it that you're aiming to achieve? Is it just a feather in your cap? Or are you actually trying to bring about change in the life of patients, in the life of learners, in the overall health infrastructure of a particular country when we are talking about collaborative learning, when you're talking about collaborative service provision? So it is not only about changing power. It is about changing power. It is not only about changing the language. So just a couple of things, as we are going to be hearing a lot of cases today. A simple case discussion can be developed into an adaptive protocol, can be implemented by teams. Through this team implementation, we can generate data that can be captured, ensuring that we are capturing all the variables that we desire to capture. That result in a quality initiative, which can easily result in development of a high level manuscript. If you have enough literature, if you have enough data, then you can certainly influence policies. You can change the way things are done. It is a slow and tedious process, but all of this is going to contribute towards how things are done in your department, in your hospital, in your healthcare organization, in your country, in your region, and then across. Key is to use standardized emergency care data, and scholarship should emerge from care improvement and should not run parallel. So, how do we ensure meaningful capacity building? every capacity building endeavor should measure more than the attendance and the learner's level of satisfaction. We should track learners, we should track teams, we should track the processes, the outcome, ensuring that there's equity and partnership, and those indicators need to be captured. We should include reciprocity and people-centered measures, not only productivity. Uh, Everybody talks about dashboards, so I sort of used generative AI Copilot to produce this learner dashboard. I told them to make me a dashboard that is capturing certain components of an educational program that I want to evaluate. And this helps us in moving from anecdotal practices towards actual stewardship. We can measure and keep track of our learners' competence. We can understand how protocols are implemented, how well is their uptake. We can talk about triage and time matrices. We can talk about length of stay. We can talk about wait time, left without being seen, all of it in a very scholarly manner. We can talk about condition-specific care processes and patient outcomes. And we need to ensure and measure how everybody in our department is contributing to this intervention. We can also measure authorship equity, and both sides of the partnership can identify what they've learned from each other. So, another thing that I have found is that we need to start asking better questions and replace deficit questions with reciprocal ones. For example, what can travel from our setting to yours? How should this protocol change in our context? And what should we measure together? So, the key takeaways for us working together is that we need to publish together whatever collaborative endeavor we are undertaking. We need to produce some kind of scholarly work out of it. Because if you're not publishing, somebody sitting in similar circumstances, such as yours, might need to reinvent the wheel, which they really shouldn't be doing. So, putting your work out there, describing your challenges, describing your scenario, describing your solutions to problems might actually help others in coming up with solutions that might be similar, that might work similarly in their context. And publishing together works, does the magic. Uh, Collaborations should be sustainable. Collaborations should not be cross-sectional. They should be sustained through mutual respect, through accountability, through keeping it as clean as possible, as transparent as possible. And these connections are nurtured through honesty. These connections are nurtured through mutual respect. These connections are nurtured through understanding each other's limitations and acknowledging what can be done while remaining within your own boundaries. Every collaborative endeavor should lead towards local improvement and capacity building. It should not be a one thing, it should span across uh, time zones, it should span across continents, and it should bring about a change, no matter how small the change is. It should add value to the context and lead us to ask better questions. So all of this needs to be done by the leadership, by the residents, by their teachers. And I am sitting here today with a very heavy heart because my teacher, my supervisor, my mentor recently passed, and I would like to dedicate this to her because through her I learned a lot of things. She was an amazing person, a force of nature, and it is a sad day for all of us to not have her with us. And please note that all of the residents who are here, all of the fellows who are here, a lot of the work that you will carry forward, a lot of the work that you do and will be doing later in life will be influenced by your teachers, by your supervisors, by your mentors, by the people around you. So learn from the best, make use of what you've learned, carry it forward, and be the best possible version of yourself every day. Your today should be better than your yesterday, and your tomorrow certainly needs to be better than today. Give yourself time, give yourself time to take a break. Uh, be cognizant of the life and the work balance, not the work-life balance, but the life and the work balance. That is of utmost importance. Uh, know who you are, know what your strengths are, also know your limitations. Live to fight another day, not every fight needs to be won. And with that, I would thank you for your time and your patience. Thank you.
Wonderful. Dr. Ali, thank you so very much for those inspirational words. Fantastic as always. I always love hearing you speak, always learn more every single time. And I think your mentor, Dr. Naseem, would be very proud to have you give the keynote today. So our condolences to you and your team. I met Dr. Naseem. She was a wonderful person, wonderful mentor. And thank you so much again. I think you've done her proud with the keynote today. So thank you so much. We do have time, I think, for one or two questions. If you would like to ask them, we can unmute you. So if you would to ask your question verbally, you could raise your hand and we can unmute you to ask it. You can also post in the chat as well too. But again, thank you so very much for those inspirational words. I think you touched on exactly what we're trying to do here today. It's all about a community of practice, exchange and not transfer, and collaboration, that being essential with this. So that's the purpose of this session today with all these cases, everyone learning from each other, us learning from you, you learning from us. And we're excited to get started with the cases here shortly. But before we do that, any questions for Dr. Ali? Right, I don't see any hands just yet. If people do have questions, please do post them into the chat. We'll be monitoring that as we go along. But let me then orient you to the rest of the day and how things will be going. So we will be having our first 10 presentations coming up here shortly. Thank you all for all of your hard work in recording the presentations ahead of time. That will help us stay on time and be able to move from presentation to presentation. So we will start with the first 10 recorded presentations per the agenda now. We will have a short 10-minute break in the middle where we'll be doing some interaction with some questions for you all. And then finish the second half of the case competition with the last 10 presentations. And then we'll just need a little time at the end because we'll be doing the People's Choice Awards with live voting. So be sure to stick around until the end because we do want you to be able to vote for your People's Choice Award. We'll need a few minutes at the end just to tally the results, and then we'll be announcing the winners of the competition at the very end. So, all right. With that, I think we will go ahead and get started with the first cases. Thank you all so very much. And a huge thank you again to Dr. Ali for that wonderful keynote address.
Good morning, everyone. I'm Dr. Julia Schiff. I'm one of the emergency medicine physicians at University of Pennsylvania. I'm here with Dr. Piers Curran, and we're going to be helping to introduce the sessions. But we also want to encourage, if any presenters are here, to let us know so that people can actively ask you questions in the chat, and feel free to raise your hand at any time so we can answer your questions or sort of engage with questions at the end of the 10-minute session. And that being said, let's start with our first case. So we're wanting to introduce Dr. Ajan from Ethiopia, who will be presenting the first case.
Good morning, everyone. My name is Ajan Mahmoud. I'm from the hospital in the Medical College, and today I will present you the case of computed hepatic fibrosis present with massive hepatic fibrosis and website thrombosis. We have larger hepatic malignancy. So the patient initially presents with rise of swelling and headache of severe exploration. For that, would suffer proteins decreased thrombosis and shows perform anticoagulant and shows instant. 2 weeks later, we present with right abdominal pain and vomiting. For that, they must also have remarkable for market nuclear and stable is 5.3, which is severe anemia. Other investigations like CBC, like WBC, and school examinations were unmarked. Abdominopathy, abdominopathy is remarkable for massive divided weight and size thrombosis, including pulmonary, local, and complicated thrombosis. Then complicated fibrosis, rupture, hepatic mallumination, and liver abscess were considered as a differential diagnosis and chose referred to our hospital. Then we consider complicated fibrosis as a unified diagnosis because it has marked nuclear hepatic hemorrhage and Charles site-based thrombosis, total vein thrombosis, as well as and another evidence is the recent searching of such serological and clinical reports in fascial fields is another evidence hepatic fibrosis. Once again, for microbiology, nuclear and absence of financing lesion and absence of with much thrombosis. Then we transfuse the patient with papillary and anticoagulant was continued. Definitive therapy and parasite therapy was initiated and invasive diagnostic issues like biopsy and range away. In follow-up, we have significant clinical and immunologic response and the resume as normal. There is significant regarding this this is initial city associated with subcalcular but on the follow-up unit, there is significant change in the subcalcular. So due to this and satisfactory response after antiparasite therapy, fascial hepatica is supposed to pass differential diagnosis. So in the past years, we have been experiencing studying of fascial diagnosis, and usually the patient presenting this hepatic hemorrhage is nuclear, non-sufficient as thrombosis. Then we conducted an additional meeting to create awareness about fascial for and diagnosis. Fascial is neglected tropical parasite disease caused by fascial hepatica, and it causes significant complications problem, but there is inadequate research in it transmits to the human variation of contaminated water and vegetables, and it causes hepatic hemorrhage and this pancreatitis. Thrombosis is usually due to localized inflammation, nuclear disruption, and massive cerebral malnutrition. The coexistence massive hepatic hemorrhage inside the thrombosis closely mimics hepatic malnutrition, causing a significant diagnostic dilemma. If initial presentation as adequate thrombosis and atypical and often overlooked manifestation for diagnosis, mycosis points are hepatic hemorrhage. Hepatic fasciolasis should be differential diagnosis in efficient thrombosis who present with atypical marked nuclear and thrombosis, and early recognition is important as antiparasite therapy can reverse severe complications and misdiagnosis may be understand invasive procedures like biopsy and brilliance, salmonellosis.
Okay. So I'm Dr. Karan. I'm going to introduce our next speaker coming from South Africa, Dr. Manjani.
Good day. I'm Amkhalang Mangani, presenting on behalf of the Emergency Department at Steve Biko Academic Hospital and the University of Pretoria, South Africa. Thyroid disease is encountered frequently in emergency medicine, with severe thyrotoxicosis representing a rare but life-threatening endocrine emergency. Its association with hypercoagulability is increasingly recognized Yet management in low resource settings often requires adaptation of standard protocols according to medication availability and local resource constraints. My fellow thrill seekers, there are no relevant commercial or financial disclosures, and the relevant patient consent was obtained for academic purposes. Representing the case of Mrs. R.M., a 29-year-old female with poorly controlled hypothyroidism following treatment interruption. She presented to the emergency unit with severe palpitations, fever, gastrointestinal upset, agitation, and progressive confusion. Her social history was notable for medication non-adherence related to financial and access barriers. Her past medical history showed previous venous thromboembolism requiring anticoagulation, complicated by warfarin-induced skin necrosis, necessitating transition to direct oral anticoagulation, which had also been interrupted. On arrival, she was confused with features of undifferentiated shock. She had a shock index of greater than 1, tachycardic, pyrexial, with features of respiratory distress. We also noted that she had features of an acute decompensated heart failure, and upon investigation, her PF ratio was found to be less than 200, indicating mild ARDS, possibly requiring non-invasive positive pressure ventilation. On examination, we found features of thyroid orbitopathy, an enlarged goiter, and a Berthold-Trotsky score of 60, requiring aggressive multi-level management in a monitored bed. Her arterial blood gas showed a respiratory acidosis with incomplete metabolic compensation with a hyperlactatemia of greater than 6. In view of this undifferentiated shock, we had to rush to a rush exam and look for a source of this profound shock. We found that she had a plethoric non-collapsible IVC with limited variability with respiration, global cardiac dysfunction with 4-chamber dilatation and a large left ventricular thrombus, no features of a large PE, and there was no free fluid noted in her abdomen. Her lung ultrasound showed that bilateral multiple B lines consistent with pulmonary edema with no pneumothorax noted. On the limited compression ultrasonography, we saw that there was a right femoral deep venous thrombosis. The simultaneous presence of intracardiac arterial thrombosis and peripheral venous thrombosis in the context of thyroid storm represented a striking and highly unusual thrombotic phenotype. Our management priorities here included emergency stabilization with oxygen therapy, escalating to non-invasive positive pressure ventilation, balanced fluid resuscitation under ultrasound guidance, beta blockade, corticosteroids, Lugol's iodine, gentle diuresis, and broad-spectrum antimicrobials. Her lab results showed a positive inflammatory process, and culture showed a positive Klebsiella pneumonia, suggesting that this could be a distributive cause of her shock, together with a cardiogenic cause. She also exhibited a microcytic anemia and a negative beta-8-CG. Important differentials here to exclude were pulmonary embolism, occult malignancy, and in the setting of our environment, tuberculosis. Now, carbamazepine was administered in place of propylthyrouracil, and despite it traditionally being used in thyroid storm for the T4 to T3 conversion, the limited availability necessitated adaptation of guideline management using accessible alternatives. She was eventually transferred from a high dependency care to a general ward and ultimately discharged home. This case illustrates a rare but critical emergency medicine presentation, and in a resource-limited emergency setting, bedside ultrasonography was instrumental in rapidly identifying life-threatening pathology. Evidence-based adaptation of standard treatments are usually the gold standard, but in our setting, we need to make sure that we use resource-constrained emergency care environments and settings. These are my references, and I thank you for your time.
Thank you so much for that great presentation. Our next presenter is Dr. Asama Boachi from Ghana.
Hey.
is a factor that has come up watching. The same thing we have asking the 74 year old man working to an Indianized daily work this is a story of how a person made diagnosis and assessing the results without highly complex scientific. Before we begin this story, have no conflict of interest, no external other different. Rule of the color of the written patient consent. All identifying information are removed from the. With our patient, a 74-year-old young man, he works into cancer emergency department self-ambulatory and adolescent. Also, as he's had a mild symptomatic pain for 2 weeks, not sudden, not staring, heart palpitations, and gets tired walking up to the came to imagine 4 out of 10. Recently diagnosed hypertensive, started on amlodipine, 5 years smoker, social drinker, no cardiac history. His vitals, blood pressure of 160/91, heart rate of 90, saturations of 97% on room air. That sounds were normal, no normal, and in the surface, this could be 100 things. But one of those things, the most dangerous things of people. This TV showed a lot of people hyperconfused, no SP changes, which was reassuring until the troponin came back at 0.08. That's where the cap begins. LVH plus check. Disease, the complexity, the infrastructure, serious out of which the patient was managed conservatively with beta calcium canal block ARBs. Focus on CTA gave us a diagnosis. The abdominal longitudinal 5.37 cm. In the subtype, you can see the intimal flap which moves with fairly at speed. Yes, you see the emission that is section. And on the gastric oblique, you have the true domain, the first domain, and in between what is separating them is our intimal flap. First type A, B type K type 1. The third began on the aortic root and targeted to the descending aorta, after the descending thoracic aorta, the abdominal aorta into the right common cardiac. Focus made a diagnosis. CTA showed us what we were doing. We started response therapy immediately. IV alone targeting systolic below 100. That was extremely prepared. The clinical effect would not be compared. The standard disease, the complexity, the infrastructure, serious out of which. The patient was managed conservatively with beta blocker, calcium canal blocker, ARBs. Focus on CTA gave us a diagnosis. Treatment remained these features. Atypical is typical. Up to 20% of dissection present without serenity. Not hypertensive, big chest symptoms. The positive sign transforms the tempo of care. Not for the performing crowd. Mild negations in dissections reflect aortic stress. This is a something population before ruling out dissection can be fatal. Know your population. High hypertension prevalence. Low the thyroid data, the speed protocol study, and the growing purpose the future in emergency medicine. This case belongs to our patient who gave us permission to share his story so that others may lead. Thank you very much. And in a resource limited setting, like the best step.
Okay, I'd like to introduce our next presenter here from Vietnam, Dr. Nam Lee Trung.
Welcome, ladies and gentlemen. My name is Lê Trung Nam from Vinh University, Vietnam. It's my great honor to present you the challenging clinical case of ischemic stroke concealed beneath the mass of severe hypoglycemia, a scenario that demands clinical vigilance and diagnostic intuition. This case prepared for education only and preserved confidentiality. A 78-year-old female presented to the ED with the acute right side hemiparesis. Symptoms began 2 hours prior, including non-thunderclap headache, right side weakness, no nausea, vomiting, fever, neck stiffness, negative for head trauma, for seizure, or loss of consciousness. Using the ABCDE approach, the classical was 14. She demonstrated the right side weakness with a mortar, strength 3 out of 5. While sensation and coordinations remain intact. This score was 4. At this stage, our differential diagnosis including vascular like stroke, hemorrhage, TIA, infectious cause, toxic, drug overdose, metabolic, severe hypoglycemia, electrolyte disturbance, trauma was considered less likely in this patient. Following the initial assessment, we immediately established IV access, performed baseline glucose testing, reviewed a significantly low level, 2.1, promptly administered the IV bolus of 50% dextro targeting the glucose level above 4 within 30 minutes. Given the history of type 2 diabetes on the sulfonylurea therapy, that micron MR 60 milligram daily, although she on weight loss meal. She also have the chronic AFib treated with the episaban 5 milligram twice daily, neuro consultation, note for the peer motor hemiparesis only. Also other laboratory investigation or diagnostic inclusions. Following 40 to 50 minutes later, additional laboratory tests including CBC, CMPs, coagulation, combined electrolyte panel, and CT with CTA all returned, and surprisingly completely normal. Based on the clinical presentation and available investigation, our preliminary diagnosis was sulfonylurea associated severe hypoglycemia. However, to be clear, the acute ischemic stroke has still not been definitely excluded. 1 hour later, repeat glucose and also neuro reassessment. Glucose has normalized to 4.8. However, the patient neural deficits failed to improve and instead persist. Accompanied by my residual dysarthria, at the critical moment, an important question emerged in our mind is that could isolated severe hypoglycemia alone truly explain all of these persistent findings? Given the patient advanced age and also long-standing history of diabetes, AFib, we did not hesitate to proceed with the urgent MRI imaging. 30 minutes later, MRI revealed an acute to subacute punctuate infarction in the right parietal lobe, 6 millimeter infarction involving the left posterior lip of the internal capsule and the left posterior external capsule. No hemorrhagic transformation, midline shift. This finding immediately changed our entire perspective. The final diagnosis became multiple acute lacunar ischemic stroke concurrent with the sulfonylurea associated severe hypoglycemia. The treatment switched to the IV thrombolysis within the first 1 hour, temporarily dabbed with the aspirin and clopidogrel, plus the management of underlying comorbidities. Thanks to the rapid clinical recognition, timely diagnosis, and also immediate intervention, the patient demonstrated significant neural improvement within the first 5 days and subsequently continue on the outpatient rehab PT. From this clinical case, we have 3 highlights. First, hypoglycemia is one of the leading causes of the stroke mimic. Fortunately, it can be identified rapidly, conveniently, and cost-effectively through the bedside glucose testing. Third, the bedside glucose remained integral component of the AHA stroke evaluation guideline for more than 2 decades. Second, TAM is brand. A single initial diagnosis should never prematurely close the diagnostic process. Continual reassessment and also close neural monitoring are essential to avoid missing life-saving, time-sensitive reperfusion opportunities. Finally, and perhaps most importantly, the clinical examinations and paraclinical investigation must always work hand in hand. As physicians, we use investigation to support and strengthen our clinical reasoning rather than relying solely on tests to make our diagnosis for us. Only when we truly master integration of clinical judgment and diagnostic evidence can we genuinely save patient life. Thank you for your listening.
Thank you. Next, I'm going to introduce our presenter, Dr. Shah from India.
Good morning, everyone. Myself, Dr. Nishita Shah. I'm PGY3 Emergency Medicine resident from Max Emergency Department, Seattle, in India. Today, I'm presenting a case titled Early Clues in the ER, its early recognition of myxedema from very arrhythmia and hypothermia. I'd like to acknowledge and thank my mentors, Dr. Adrian, and my HOD, Dr. Veena Singh, for their guidance and support in this case. Annual financial disclosures and patient anonymity and confidentiality has been maintained in this case group. A 54-year female patient presented to the emergency department with generalized weakness for 1 week, associated chills, poor appetite, and further psychosis syndrome. As per attendance, she has been bedridden for last 3 days. She was a known case of hypothyroidism but was non-compliant with medications. On arrival in ER, the patient was critically ill. Her heart rate was 37 beats per minute. Blood pressure was non-recordable. Respiratory rate was around 20 per minute. And oxygen saturation was maintained in ER. Her blood glucose were normal. Neurologically, she was mildly confused with GCS of E4, V4, and M6. The remainder of the system examination was largely unremarkable. Blood workup and investigations were done. ABG was done in ER, which showed respiratory acidosis pH of 7.31 and elevated PCO2. ECG was done, which demonstrated seamless bradycardia with along the presence of G wave or Oswald wave, which suggested hypothermia-related cardiac changes. We needed focus in ER, which showed normal EF55 and IVH was plethoric. CT head was done keeping in mind the neurological status of the patient. We did not have read, which showed any diffuse cerebral ectrophy. This slide shows the ECG showing G wave and Orson wave in V2, V3, V4, V5, and V6. At presentation, our differential diagnosis included myxedema, sepsis, myocardial infarction, hypothermia, hyponatremia, and adrenal insufficiency. The patient was managed aggressively in the emergency department. She received intravenous steroids, normoxidine, along with atropine for symptomatic bradycardia. Empirical hydrocortisone was also administered early. Due to persistent hemodynamic instability, transcutaneous pacing was initiated and vasopressor support with noradrenaline and dopamine was started. Prospective antibiotics like piperacillin, tazobactam, potassium gluconate was also administered as empiric treatment before lab results were obtained. Active reworm measures were undertaken to address hypothermia. Following confirmation of thyroid dysfunction, levothyroxine therapy was initiated in the ICU. The patient was admitted to the ICU for monitoring and management. This case highlights the importance of recognizing myxedema as a rare but life-threatening endocrine emergency. The presentation can often be subtle and misleading. In this patient, the hypothermia was unexplained bradycardia and the presence of observable wave in ECG is served as an important bedside. The case also demonstrates the importance of correlating thyroid function tests clinically, especially in critically ill patients where laboratory findings may appear discordant. Myxedema should be considered in patients presenting an unexplained hypothermia, insomnia, and arrhythmias, particularly in the setting of hypothyroidism. Its early recognition and prompt treatment in the emergency department are essential to improve outcome of the patient. These are the key references used for this presentation. Thank you for the opportunity to present today.
Okay. And next for our presentation from Vietnam, we have Dr. Trung Hu Huong.
Hello everyone, my name is Trung, a medical student from Penn University. Today we're going to present a case regarding hemophilia. Before beginning the clinical discussion, please note that the patient have gave written informed consent for the publication and the authors declare no conflict of interest and received no external funding for this report. Okay, so our patient is a 62-year-old man who presented to the emergency department with a chief complaint of worsening dizziness and colicky abdominal pain. He completely denied other associated symptoms, and the night before admission, he had 3 episodes of childlike melena with a moderate amount. This was accompanied by a milder episode of colicky abdominal pain. His bad medical history significantly highlighted a 5-year history of alcohol-related liver disease with prior esophageal varicose bindings on 2 separate occasions. Upon initial examination, the patient was alert and oriented. We observed clear clinical signs of decompensated cirrhosis, signs of anemia, signs of upper bleeding. Abdominal examination is significant for epigastric and umbilical pain upon deep palpation and negative for Murphy signs. Quick lab was done and showed evidence for normocytic anemia with elevation of bilirubin and GGT. Ultrasound is also been done and revealed only cirrhosis morphology with portal vein thrombosis and cholelithiasis, partially ruling out other biliary tract problems. In summary, the clinical picture standing out was a decompensated cirrhosis patient with GI bleeding and advanced medical history of esophageal varices. Given that, our immediate presumptive diagnosis was ruptured esophageal varices, and we proceeded with an emergency endoscopy while we did visualize the grade 2 esophageal varices. On the endoscopy, there was no active bleeding points identified anywhere in the GI tract. So in order to locate the hidden sources, the team escalated imaging to a contrast-enhanced CT. The imaging showed dilation of both intrahepatic and extrahepatic biliary tracts, and the most critical finding, however, was an unclear mass with contrast enhancement in the arterial phases. And with that suggesting evidence, the presumptive diagnosis heavily shifted to simultaneous hemophilia resulting from a hepatocellular carcinoma, and the patient was initiated for berazole and amikacin for cholangitis prophylaxis, along with fluid resuscitation and lactulose to prevent hepatic encephalopathy. The patient was then transferred to the GI department, and on the second day of his disease, the second endoscopy confirmed hemophilia by showing bleeding from the ampulla of bladder. And a tumor marker panel for HCC was also ordered to investigate it, and it also increased. Therefore, we indicated angiography and transcatheter arterial embolism for the patient to definitely confirm the diagnosis and hold the bleeding. However, both the patient and his family denied the procedure, and the patient therefore is managed without intervention. During his management in the GI department, he has one episode of fever on the second day with an elevated CRP and elevated neutrophils. And because of our quick course of action in diagnosing the bleeding point, the team have quickly identified the infectious source, which is ascending cholangitis, and we immediately performed blood cultures and escalated the antibiotic regimen to meropenem and amikacin. From that, the patient cholangitis improved and his vessels turned yellow on the fifth day, proving that the bleeding has stopped. And on the seventh day, the patient was discharged to continue his treatment at a provincial hospital. Okay, so this case leaves us with three vital clinical takeaways. The first one is that we must always be aware of the anchoring bias. A prior history of varicose bleeding dangerously narrows our differential diagnosis. The Sandblom triad for hemophilia may lose their specificity when a severe underlying disease such as cirrhosis mimics the clinical pictures. Second, spontaneous hemophilia secondary to ACC must remain a high priority differential, especially in resource-limited countries where ACC surveillance is low. In this case, despite an unconfirmed diagnosis, early detection and prophylactic antibiotics has minimized the complications. When a fever develops, on the next day, we quickly localize the infection and adjust the antibiotic regimen and ensure a rapid recovery for the patient. Finally, this case highlights the value of early contrast enhanced CT in evaluating the GI bleeding. It is fast and provides a quick overall clinical picture for identifying GI bleeding sources before going for a mesenteric angiography or a colonoscopy in emergency department.
Thank you so much. Our next case is from Dr. Guragan from Nepal.
Hello everyone, I'm Dr. Nicole Guragan from Department of General Practice and Emergency Medicine here at Patan Academy of Health Science in Nepal. I'm here along with Dr. Kripa Maharjan and Dr. Prikuti Yogi, and we present you a case of dengue hemorrhagic shock with acute liver failure who has been treated with N-acetylcysteine and corticosteroids. The drug N-acetylcysteine is primarily used in acetaminophen-related poisoning, but here we have used the same mechanism of action for management of acute liver failure in patients with dengue. We have no conflict of interest to declare, and we have obtained written informed consent from the patient and parents. We also declare that this is original work and has never been previously presented or published. We present you a case of a 15-year-old female who has already been diagnosed with dengue with NS1 positive in another center and was referred to our center for ICU support for progressively worsening liver enzymes and worsening GCS score with provisional diagnosis of acute liver failure in the background of dengue. In our institute, while examining her, she was hypotensive, tachycardic, tachypneic, hypoxemic with altered sensorium. The general condition was also ill-looking, drowsy, lethargic with cold and clammy extremities. So she's clearly at the state of shock. On systemic examination, the chest findings were suggestive of bilateral pleural effusion, whereas for abdominal findings were suggestive of hepatosplenomegaly with ascites. So the main provisional diagnosis that we kept here was dengue hemorrhagic shock with acute liver failure. So the main, while she was in shock, we used the main core treatment in emergency management of any patient, which starts from ABC, airway, breathing, and circulation. First, we maintained the airway through intubation. We gave mechanical ventilation as a support for breathing. We also maintained circulation with the use of 2 IV bore cannula with aggressive fluid resuscitation followed by transfusion of blood products. Even after fluid resuscitation, the patient needed vasopressor support. We also sent the investigations and the patient was transferred to ICU after the emergency management was done for hemodynamic monitoring and support. While at our center, we saw that compared to what she had in the previous center, the liver enzymes were decreasing, whereas the bilirubin was increasing from 9.9 to 13.9 and PTINR from 1.21 to 1.4. So you can clearly see decreasing liver enzymes, whereas increasing the bilirubin and PTINR, which is bilirubin enzyme dissociation. So this along with the hepatic encephalopathy strictly guided us toward diagnosing of acute liver failure. So after this diagnosis, we gave the patient IV N-acetylcysteine in a standard 21-hour dosing, which is also similar to what we use in acetaminophen-related poisoning. We use we consider the same mechanism of action of this drug, and we admitted the patient along while giving N-acetylcysteine and corticosteroids. And we continuously monitored the liver enzymes and the vitals of the patient while she was there in the ICU. So the corticosteroid was continued, whereas the N-acetyl was stopped after 21 hours regimen. While looking at the patient in the ICU, the patient recovered, was alive, neurologically intact, and the patient was shifted to high dependency unit and then was shifted to ward. So in the lab findings, 24 hours after the N-acetylcysteine therapy, the platelet count here is increased primarily due to transfusion of blood products. But just look at the liver enzymes, because the liver enzyme has again increased, which is like suggestive of the washout of these liver enzymes, and the bilirubin and PTINR is also improved just after 24 hours of N-acetylcysteine plus corticosteroids therapy. And just before the discharge, after she was transferred to SDU and ward, the liver enzymes and the synthetic function of liver was also improving. Whereas in the follow-up period, after 7 weeks of after 7 days of discharge, the patient's liver enzymes were normal. So the mechanism of N-acetylcysteine we used here are like similar to that of N-acetylcysteine in acetaminophen related poisoning, and we have also got few other case articles where they have used IV N-acetylcysteine and also had significant recovery in the patient in whom this drug was used. So the teaching point we have was we can use N-acetylcysteine in dengue-related acute liver injury, and we would also suggest for the RCTs that are needed to like support the point of use of N-acetylcysteine in patients with acute liver failure in dengue endemic regions. Thank you.
Okay, next up from Vietnam, we have Dr. Tri Hu Minh Pham.
Hello everyone, my name is Tri Pham, a final year medical student, and today on behalf of my teammates, Sơn, Chan, Anh, and Duyên, I will present our case. When vomiting signals the brain, pediatric intracranial hemorrhage in an adult-focused emergency department. This case comes from 108 Central Military Hospital in Vietnam in collaboration with Penn University. This case is presented for educational purpose. Patient identifiers were removed, consent was obtained for anonymized clinical information and images, and we have no conflicts of interest or external funding. Our patient was a previously healthy 10-year-old girl who was first presented to an adult-focused hospital with abdominal pain, repeated vomiting, and persistent headache about 4 hours after eating food purchased from a street vendor. The symptoms started suddenly when she was playing with her siblings. Shortly afterward, her parents had difficulty waking her. She became less responsive, irritable, and continued to complain of headache. On admission, she was not completely unconscious and had no obvious paralysis. Instead, she was lethargic, somnolent, partially responsive, and poorly followed commands. Her parents also reported no fever, diarrhea, or trauma. Because she had repeated vomiting after food exposure, these symptoms could initially be interpreted as simple fatigue from gastrointestinal illness. Her airway, breathing, and circulation was stable. She had no respiratory distress, no signs of dehydration, and her abdomen was soft without tenderness or rigidity. Her vital signs were mostly stable. The main abnormality was neurologic. GCS was 11 out of 15 with E2, B4, and 5 with incomplete neurologic assessment due to somnolence and poor cooperation. Initial investigation did not support an abdominal source of illness. Abdominal ultrasound showed no evidence of appendicitis, bowel dilation, or free fluid, and chest X-ray was unremarkable. At this point, food exposure still made gastroenteritis or food poisoning seem plausible, but the persistent headache, lethargy, abnormal behavior were not well explained by a simple GI illness. On reassessment, the concerning findings persisted. She remained lethargic and somnolent with abnormal behavior, and the physicians noted right gaze deviation bilaterally. The family became increasingly worried and emphasized that this was a marked change from a usual calm and cooperative baseline. The team first suggested CT imaging, but the family was hesitant because of cost and uncertainty about whether it was truly necessary. After continued reassessment and a second discussion, the physician again explained that this neurologic red flag could represent a life-threatening intracranial process. With this clearer risk-benefit explanation, the parents agreed to urgent CT. The contrast head CT revealed a key diagnosis, a right frontal intraparenchymal hematoma with intraventricular hemorrhage. The likely cause was rupture of a right frontal vascular malformation, suspected to arise from the anterior cerebral artery territory with no draining vein visualized. This explains why vomiting and ulcer behavior in this child should not be treated as uncomplicated GI disease. After diagnosis, she was treated with mannitol and tranexamic acid and then quickly transferred to the National Children's Hospital for definitive pediatric neurosurgical care within 12 hours. By day 5, she was alert and conscious without irritability, headache, or focal neurologic deficit, and was discharged after recovery. This case provides 4 key lessons. First, the repeated vomiting should trigger a broader differential diagnosis, especially when it occurs with headache, behavior change, or altered consciousness. Second, clinicians should actively look for neurologic red flags. In pediatric intracerebral hemorrhage, altered consciousness may appear before the obvious focal deficit. Third, after stabilization, early imaging is essential. MRI, or CT-CTA with vascular imaging may be used when indicated. But when hemorrhage is suspected and MRI is not immediately feasible, CT is a rapid and high-yield first test. Fourth, communication is pivotal. When CT cost is a barrier, clinicians must address financial concern with empathy while clearly explaining the danger of missing a life-threatening diagnosis. In conclusion, pediatric intracranial hemorrhage can mimic food-related gastrointestinal illness. In this case, repeated reassessment, caregiver history, recognition of subtle neurologic red flags, and clear risk-benefit communication enable timely CT diagnosis and transfer. Thank you for listening.
Thank you. Up next, we have Dr. Zalunjo from Nigeria.
My name is Dr. Oni Zalunjo from the Department of Medical Oncology, Lakeshore Cancer Center, Lagos, Nigeria. Today, I'll be presenting a case titled High-Risk Airway Management of Malignant Supravenous Syndrome with metastatic breast cancer in a resource-limited setting. I would like to acknowledge my mentor, Dr. Chineye Wuji, my team members, Dr. Akimomi and Dr. Kana, as well as the recommendations from our multidisciplinary meeting, which will contribute in the management of this patient. There are no conflict of interest, no financial disclosures. The patient information have been fully anonymized to protect confidentiality, and this case is presented in accordance with the institutional ethical standards. Now, superior vena cava syndrome is an oncologic emergency due to obstruction of venous return from the head, the neck, and the upper extremities. Malignancy remains the most common cause, with common culprits like lung cancer, lymphoma, with metastatic breast cancer being a less frequent etiology. Now, airway management in these patients can be a serious complication because sedation and muscle relaxation, as well as positive pressure ventilation, can worsen mediastinal compression and impair the venous return, potentially leading to cardiovascular collapse and eventual patient demise. Now, the case presentation of today is centered on a 53-year-old lady with a recurrent hormone receptor positive, HER2 negative invasive ductal carcinoma of the right breast. She presented in 2015 and she was diagnosed then with following lumpectomy and a sentinel lymph node biopsy. She declined adjuvant endocrine therapy on personal reasons at the time. And then in 2020, she had a recurrence involving the chest wall, axilla, and internal mammary lymph node. And then she went in multimodal line of treatment involving systemic therapy, surgery, radiotherapy, and adjuvant and endocrine therapy. She was presented again in 2023 with malignant superior vena cava syndromes for mediastinal mass. She received palliative mediastinal radiotherapy, which resulted in partial improvement of her symptoms. Now, in 2024, she had an SVC syndrome. This time she presented with progressive spatial swelling, upper lymphedema, and dyspnea. And on examination, she was tachycardic, mildly dyspneic at rest. If you look at the picture in front of us, the red circle highlights the engorged superior vena cava, which was consistent with facial and neck swelling. The right anterior chest appeared fibrotic on prior treatments, as well as just consistent with previous surgery and radiotherapy. And left breast was diffusely engorged, which was also consistent with impaired venous and lymphatic training, secondary to superior vena cava obstruction. So a particularly important finding we noted on full examination was that oxygen saturation remained normal while in an upright position, so it was around 96-98%, but it drops significantly to around 80-85% in supine position. Now, this positional desaturation raised major concern for critical mediastinal compression and impending airway compromise. So we requested a chest X-ray immediately, and it showed bilateral pleural effusion, which was markedly on the right. Thoracosynthesis yielded serous and venous fluid, and the right chest tube was inserted. Unfortunately, due to our declining status, we could not request for further imaging at the time. And then subsequently, she received opioid analgesia for chest tube-related pain. And then shortly afterwards, she became increasingly drowsy and was in respiratory status. Although the naloxone provided partial improvement, a persistent positional hypoxia on background mediastinal compression strongly suggested airway compromise rather than isolated opioid toxicity. So an urgent MDT meeting was convened involving our medical oncology and other specialties involved in our care. And the major concern at the time was that induction of anesthesia and positive pressure ventilation would further precipitate complete airway compromise. Now, regardless of the risk involved, the consensus was that airway protection was necessary because her case was progressively deteriorating. So she had underwent an urgent controlled endotracheal intubation, which was successful, and then she was sent to the ICU for mechanical ventilation for about 3 weeks. She spent about 3 weeks in the ICU. And during this time, once she was stabilized, she had an SVC stent put in place, which was successful. And then she was monitored. So she was eventually intubated with CPAP and discharged home. Now, she died 4 months later due to disease progression. This X-ray was taken in the ICU shortly before discharge with so many findings to highlight. So we could see that the SVC stents for SVC obstruction. And we could also see the right internal jugular line within the SVC stent located there, as well as a significant right pleural effusion with the chest drain placed inside. And she also had a right-sided mastectomy as evident from the chest X-ray. So the key learning points are that positional hypoxia remains a red flag for impending airway compromise. Supine position may precipitate severe decompensation. Sedation and PPV can worsen mediastinal compression. MDT is essentially crucial in high-risk airway cases because even in resource-limited setting, it's been proven to show stage stabilization, careful planning, collaborative care, which can eventually improve the outcome clinically. These are my references, and thank you.
Okay. Next up, we have Dr. Kaman Nguyen Le from Vietnam.
Good morning. My name is Cẩm Anh from University. Today, I'm so excited to present a case, acute respiratory failure during transfusion, Charlie, takeoff, or more. The key challenge in this case is how to distinguish volume overload from inflammatory lung injury while not missing PE in patient multiple comparing factors. The authors declare no conflict of interest, no funding was reserved, and no patient data have been removed. So we have a 63 years old male patient with prior unprovoked PE, initially treated with warfarin. Even after following up, showed no recurrent PE, anticoagulation was continued, and it was later agreed to enoxaparin for planned hip surgery. Importantly, after a motorbike accident with high trauma, he still continued enoxaparin himself. This contributed to a lifetime hematoma and severe anemia, recalculate, RBC, and FFP transfusion. Unluckily, after finishing RBC and 1.5 units of FFP, he developed acute respiratory failure. So what happened to me? Coming to physical examination, his vital sign was quite unstable, R26, SpO2 drop, improving with oxygen mask, hypertensive according to my fever. On the examination, they were bilateral freckles with no wheezing. There was no GVD, no peripheral edema. POCUS showed diffuse bilateral B-lines, no pleural effusion, small collapsible IVC, and RV dilation. The ABG showed type 1 hypoxemia but normal lactate. And at the time, we stopped the transfusion immediately, support airway, breathing, circulation, and notifying. At this point, there were 4 major possibilities. The first one, the patient developed acute respiratory failure within 6 hours of a transfusion, fever, and hypotension. So, consistent with suspected Charlie. Second takeoff, pulmonary edema due to circulation overload. Third, due to his PMH and recent interaction of anticoagulation due to bleeding, the RV dilation raised concern about recurrent pulmonary embolism. And finally, all those transfusion reaction sepsis. So, do we miss anything for the patient? So, we ordered for some blood tests. On ECG, the patient had sinus rhythm at 75 beats per minute, left axis deviation, and complete RBBB. No sign of S3, T3, Q3 in this ECG. The transfusion reaction woke up to support acute hemolysis. Anti-Pro-B was not markedly elevated, and it can somehow exclude the takeoff. We also checked for his previous echocardiography and found that he had the RV dilation before. So what is the answer for this patient? So imaging helped to narrow the diagnosis. Chest imaging of bilateral GGO, CTPA shows small segmental thrombi in both lower lobes, especially in S8, S9, and S10. So yes, PE was real, but the question is, what's be the main cause of this sudden respiratory collapse? It cannot fully explain the sudden onset of fever, hypertension, and bilateral pulmonary edema. So it was an important coexisting diagnosis, but we have to think more about Charlie. Why? The first, the patient had acute hypoxemia. The second one, he had the pulmonary edema pattern shown by bilateral freckles, B-lines, and bilateral lung involvement. The next one, symptoms began during FFP, and Charlie is within 6 hours of transfusion. It's not primarily hydrostatic, and he also have ARDS risk factor. So in this patient, we have to stop transfusion immediately, support oxygenation, notify blood bank, hemodynamic support, and treat coexisting problem. No specific drug reverse Charlie. Treatment is supporting ARDS as standard care. So I would like to end with 3 take-home messages. The first, this case is not about Charlie. It's about diagnostic disease under pressure. Second, do not anchor too early. Previous PE and abnormal imaging do not explain certain respiratory failure during transfusion. And the third one, separate the mechanism of pulmonary edema. This distinction depends on timing, hemodynamic, focus, congestion size, BNP, and clinical trajectory. Finally, suspected Charlie must be reported as a side effect event. Thank you for your attention.
Well, great presentations, everyone. Thank you so much. Interesting seeing such different cases from so many different places. Right now, as the judges work to compile their scores for the first half, we're going to have a little intermission where we're happy to open it up to questions from the audience. And you're welcome to raise your hand or unmute yourself or type anything in the chat based on either Dr. Ali's presentation or any of the cases. We do have some of the presenters on the call. And then we have a few questions after listening to these cases as well. But feel free to start typing in the chat or raise your hand. I guess one question I had kind of seeing everyone's presentations was about access to some of the same resources. And I'm curious if people are able to use the thumbs up and thumbs down component in the chat to let us know, just do people have readily available CT scans in their locations? It looks like most people do. What about POCUS availability? Oh, that's great to hear. It seems like most people have readily and easy access to both of these imaging modalities, which were used for a lot of these cases. Sort of asking Dr. Curran's question, but are there any management strategies or things that you saw in these presentations that are not feasible in your context or that you haven't seen before? It looks like we have a question for one of our presenters. I'm not sure if Dr. Pham is on the call, but the question is if there was any precipitated cause of the hemorrhage that they identified in the pediatric patient. I do think they mentioned something about an AVM in the. We do have one question in the chat. How can assault be prevented in the emergency room? I don't know if anyone has any comments or thoughts on that. Any final questions before we move on to section 2? Okay, wonderful. Great hearing about all of these different experiences and access that we all have in different settings. So we're going to move on to part 2. And please keep in mind for the cases for the part 1 and part 2, we'll be having you all vote on a People's Choice Award. So for our first case in section 2, we'd like to welcome Dr. Rashid from Pakistan.
Hello everyone. Today I am going to present a curious case of conscious convulsing patient for devastating impulse experiencing a seizure disorder. I am Dr. Rashid, resident emergency medicine, currently working in this hospital and health network branch. Before going into detail, I would like to mention all the pictures used in this presentation are AI generated or copyrighted. I am from Pakistan and this is our hospital and this is our emergency where we used to see about 700 patients on daily basis. I would like to declare no conflict of interest and all the patient information has been removed to protect confidentiality. Our patient, about 21 years old, healthy female, presented in emergency with history of fever and body aches for the last 2 days, for which she took unidentified Hyvel tablets. And after that, she developed frequent convulsions along with painful spasms. This striking feature in her presentation was she remained conscious and oriented. On physical examination, patient Shan healthy looking with active convulsions. She was normotensive with tachycardia and tachypnea, but was afebrile. She had no frothing urine or ventricular incontinence. No scar marks or signs of substance abuse were found. Neurologically, patient had GCS 15 out of 15. Pupils were dilated, sluggishly reacted to light. Illness could not be assessed. Motor examination showed decreased power in both lower limbs with marked hyperplexia and rigid. Upper lip examination was unremarkable. Patient had no sensory level, no managerial signs of openness or deficit. Rest of the physical examination was unremarkable. Patient investigation showed raised sugars along with high metabolic acidosis. However, blood ketone were negative and extended electrolytes were also within normal limits except by how it was low. Hematologic workup showed marked leukocytosis along with neutrophilic shift for a well-situated pulse might be elevated, CRP was normal, other workup showed raised CPK level, dengue and malaria was negative, and renal and liver function profiles were also within normal levels. During high pulse of treatment, patient was initially managed with suspected infectious disease like tetanus and meningeal hepatitis were the topmost diagnosis. And IP benzodiazepine, ceftriaxone, dexamethasone, acyclovir, inhibitor as stem was started. Patient remained conscious between spasmodic episodes during her course in the ER. And later on, she developed progressive hypoxia and went into brain arrest. Resuscitation was challenging due to severe marked rigidity, and that was impaired in ventilation and compression. Unfortunately, loss could not be achieved. This patient has diagnostic dilemma. Despite extensive workup, her diagnosis could not be reached. And after thorough literature review and in-depth discussion with only available toxicologists in Pakistan, the topmost diagnosis made for this patient was strychnine poisoning. Strychnine is derived from plants called Strychnus vomica. It acts through blocking glycine receptors in spinal cord, which result in disinhibition and recurrent convulsions. Though no active antidotes available for this poison, management is almost supportive with IDA protection and lactic breaths. All the features like acute onset, preserved consciousness, and marked reflexia key towards more towards strychnine poisoning. Other differentials like hypersensitivity, streptococcus syndrome as poor clinical control. This case also highlights global health issue in low middle income countries like Pakistan, where unregulated hypermedication and limited toxicological services increase risk of exposure toward these toxic medicines. And there is a dire need for stronger toxicovigilance system. Key takeaways are not every convention is epilepsy, preserved consciousness is state play, behavior protection can be life-saving and loss, but not the least, avoid diagnostic aspect. Thank you so much.
Okay, so next up from South Africa, we have Dr. Wusu.
Thank you. My name is Dr. Celeste Konosu, and I am an EM registrar in South Africa, Cape Town. And today I'd like to present a rare case of tension pneumopericardium with features of cardiac tamponade following penetrating chest trauma. This presentation highlights the diagnostic difficulty of tension pneumopericardium, the delays in life-saving management, and the importance of serial assessments in the emergency unit when dealing with a trauma patient. We saw a 26-year-old who presented at the primary healthcare facility with a stabbed chest, parasternal to the third intercostal space. Blood pressure score 76/40, heart rate 127, GCS 1215, HB 9.2. He had an E-front that showed bilateral pneumothoraces as well as a small apical pericardial effusion with no intra-abdominal or pelvic fluid. Patient received aggressive fluid as well as blood resuscitation. Bilateral ICDs were placed. Patient had serial EFARs. At this point, diagnostic considerations included vascular injury, major vascular injury with hemorrhagic shock, evolving tamponade with massive pericardial effusion, obstructive shock with bilateral pneumothoraces, cardiac injury with cardiogenic shock. But with the HB unchanged, with no interval change in this and the serial EFOS, with the non-resolving blood pressure with bilateral ICD placement, as well as the persistent hypotension and the worsening lactic acidosis, another diagnosis had to be considered. Patient was started on inotropic support and transferred to our facility. On arrival, patient's condition deteriorated and the patient developed features of a cardiac tamponade, but without any fluid or blood around the heart. A CT was requested that showed that the patient had a pneumopericardium of 15 centimeters, as well as a right ventricle wall injury, as well as a right IFA injury, amongst other pathologies in the chest. Patient was taken to theatre and underwent urgent surgical decompression, as well as a repair of the right ventricular wall and ligation of the right IMI. Patient was discharged day 5 post surgery. It was this particular case that brought to our attention an extremely rare but potentially fatal cause of obstructive shock after penetrating chest trauma. Tension pneumopericardium is caused by the accumulation of air within the pericardial sac, creating tamponade physiology similar to fluid around the heart, impairing ventricular filling and leading to cardiovascular collapse. There are various non-traumatic causes for a pneumopericardium, including TB, lung abscesses, GI malignancies, iatrogenic causes such as central line placement and pacemaker insertion that may introduce air into the pericardial space. In trauma patients, the diagnosis is particularly difficult because of concurrent conditions as seen in this particular case that may obscure the clinical picture. Literature, published literature on tension pneumopericardium mainly comprises of case studies as well as literature review, and consistently demonstrate the high mortality associated with tension pneumopericardium, and recommend pericardial synthesis or surgical drainage to rapidly restore circulation. Lessons learned during this, important lessons learned during this case was that tension pneumopericardium should be considered any penetrating chest trauma with unexplained or refractory hypodynamic stability, and that also mortality remains high if decompression is delayed, supporting emergency pericardial synthesis or surgical drainage as standard management. In the future, I would like in these particular cases to maintain a high index of suspicion for this diagnosis in patients with refractory shock and not delay life-saving interventions such as pericardial synthesis to improve patient outcomes and prevent cardiac arrest.
Thank you. Next, I would like to introduce the case from Dr. Abisa from Rwanda.
Hi everyone, this is Dr. Diana Abesa. I'm a PGY2 resident of emergency care and critical care at AHUSU, which is African Health Science University, which is located in Rwanda. My mentors are Dr. Tisfa Emnet and Dr. Sion. Other contributors were Dr. Munyanga Emmanuel, who's a PGY1 at AHUSU. And for disclosures, I don't have any conflict of interest, and we got the consent from the hospital. So the case I'm presenting today, it's a case report we did of bridging critical, which is titled Bridging Critical Care at Lake. It's a case of a patient we received at Kibuye Referral Hospital, which is 4 hours from the Kigali, which is the capital city of Rwanda. So we received 88 years old male patient who came in who had sudden onset of dyspnea. He was very tachypneic, he was very hypoxic, and he had a history of pulmonary embolism. He was on oral anticoagulants, which he wasn't taking so well. So when he came in, he had he was very hypoxic. He had SpO2 66 on room air, and respiratory rate was 24. So we did also ECG where we saw S1, 2, T3, and T3, and the podcast showed right ventricular strain, and it had also D-shaped left ventricular on the right-sided B lines. So this patient, this was his ECG, and the labs were unremarkable. So we put him on non-rebreather, facial mask, oxygen, and then we started exoparin 80 milligrams. And he was also given morphine, but despite the high flow oxygen, 15 liters per minute of non-rebreather, facial mask, he never improved, but he deteriorated. His BP became 87 up to 53, and his pulse rate became so weak. So we wanted to admit him to ICU for ventilator support, but we couldn't get an ICU. He had no insurance, and the city angio couldn't be done in the night because our hospital stopped working by 8 p.m. The radiologists don't work at the referral hospital, and there was lack of HFS. So at this moment, in the morning, our patient was still hypoxic, despite being on a rebreather facial mask. So, and he was still on infusion of noradrenaline. So what we did, we did CT angio, and then we got bilateral pulmonary embolism. So our diagnosis was massive PE, which was complicated by obstructive shock and right ventricular failure. So at this moment, what we did, we activated zipline, which is a drone which is used in Rwanda to transfer mostly blood from blood bank from the national blood bank to other blood banks in the country. So we asked them to deliver HFAs, which they did, and this was the first time they delivered HFAs in this country with the zipline. So this case report showed even other hospitals that they can use the resources we have to get HFAs. So as we know, so what I want us to learn from this case is that low resource limited countries, we can use what we have, like the use of focus, bedside focus, and ECG really helps in the early diagnosis. And then also we can overcome the geographical and logistic barriers by appreciating the innovation in healthcare delivery, like this zipline that we had we used, which can really translate into saving lives, especially in rural areas and remote hospitals. Thank you so much. And these are my references. So,
Okay. Next up, we have Dr. Thia Thuong Long from Vietnam.
Good day, everyone. My name is Lung Thị Ethel, and on behalf of our team from Green University, I would like to present a case that we call when stable and not stable, a case of cancer-associated pulmonary embolism with non-intensive shock, transitioning from ESC 2019 to ASA-ACC 2026. Our patient is a 77-year-old woman presented with dyspnea after mild exertion and 1 day of fatigue. She had no chest pain, cough, hemoptysis, or leg swelling, but her background raised concern. She had metastatic pancreatic adenocarcinoma with liver metastasis, primary thrombocytosis, and recent chemotherapy complicated by the cytopenia. And even before imaging, this patient already have a very high risk for thrombotic event. On arrival, she has tachycardia and tachypnea that requiring 10 liters of oxygen through a non-breathable mask, although her blood pressure remained reserved. The key findings also show a high troponin and the octane of 3.5. On examination, she has a tubular distension and cold extremity, while ECG showed the sinus tachycardia. That everything looks stable, but her lactate can suggest an underlying hyperperfusion and hemodynamic collapse before the hypertension occurred. The PESA echocardiography quickly revealed a significant right ventricular strain with right ventricular dilation, reduced function, the elevated pulmonary pressures, and also dilated IVC. Vascular ultrasound also identified the iliac vein thrombi. The CTPA later also confirmed the bilateral PE. But the critical point here is that the PESA ultrasound allows us to recognize the right ventricular failure in real time before the patient became completely unstable. What makes this case especially interesting is also the way we use the guideline to approach this patient. If using the ESC 2019, this patient will be placed into the intermediate to high risk group, with managed by the anticoagulation and close monitoring. But under ASA-ACC 2026, the combination of right ventricular dysfunction, elevated troponin, and lactate and high oxygen requirement places her into the category D2R. So instead of waiting for shock, the new guideline encouraged the doctor to act earlier with advanced therapy. But due to her past medical history, the symptomatic thrombolysis carried major bleeding risk. At the same time, the catheter-directed therapy was not immediately available due to the limited resources and also due to the family financial concerns. So we adapt, monitor, and repair strategy. We start unvaccinated heparin, repeated the lactate and echocardiography every 30 minutes, and repair the CDT team and equipment in advance. A very low threshold for escalation. Within 90 minutes, lactate continued rising, and repeat echocardiography revealed a new rhombus in transit inside the right ventricle. At the moment, the patient had not yet developed profound hypotension, but due to her rest, we discussed again with the family and get a consent. And thanks to the beforehand reparation, the catheter-directed thrombolysis were initiated within only 20 minutes after the decision was made. 2 hours later, her hemodynamic improved significantly. Oxygen demand decreased, and also for the lactate, and repeat echocardiography also show improvement of right ventricle strain. So turning to the teaching point, there are 4 important lessons that we can learn from this case. First, normal blood pressure does not always mean hemodynamic stability. Elevated lactate and right ventricle dysfunction can help us to recognize the shock earlier. Second, patient with right ventricular dysfunction, elevated troponin, rising lactate, and high oxygen requirement will require earlier reperfusion with advanced therapy without anticoagulation alone. Third, the guidelines are not one size fits all. The real-world management always be a balance between the bleeding risk, the resource limitation, patient references, and family concern. And finally, when definitive therapy is delayed, a monitoring repair strategy allows rapid escalation before the complete collapse occurs. So in PE, the shock can occur very quietly, so recognizing the warning sign can help us to save the patient. So that's all. Thank you.
Great. I want to introduce Dr. Brooks from South Africa.
Good morning. My name is Cassie Brooks. I'm a medical officer working at Groote Schuur Hospital in Cape Town, South Africa, and today I'll be presenting to you all of the pressure, none of the pulse. Emergency medicine in resource-limited settings frequently requires clinicians to make critical decisions with limited diagnostic certainty, where subtle physiological clues may be the only indication that something more complex is occurring. Today I'll present the case of a woman who initially appeared to have severe sepsis, but whose clinical presentation revealed a far more unusual and life-threatening diagnosis. Our patient was a 42-year-old woman who was HIV positive but virologically suppressed and who had poorly controlled hypertension. She presented with a non-specific history of vomiting, abdominal pain, and confusion for one day after recent travel from Zimbabwe. On arrival, it was diaphoretic, clammy, peripherally shut down, and pale. At triage, she appeared shocked, with a tachycardia of 138 and a blood pressure of 98/68. However, minutes later in the resuscitation bay, her blood pressure surged to 172/121. This fluctuation in blood pressure became one of the most important clues in this case. On examination, she was critically unwell. She had a Glasgow Coma scale of 13/15, with no meningism and no focal neurology. Her respiratory and cardiac exams were unremarkable, except for a significant tachycardia. On abdominal examination, she had a large, palpable, firm pelvic mass. Her prognostics were negative. Chest X-ray were unremarkable, but her initial blood gas showed a significant lactic acidosis with a lactate of 10.9. Bedside ultrasound revealed a large homogeneous pelvic mass arising most likely from the uterus. There was no free fluid in the abdomen. Her IVC was not distended, but she had no pericardial effusion and her DVT scan was negative. Her ECG showed a sinus tachycardia. CT brain showed only a small lacuna infarct. With regards to her septic workup, she had significantly raised inflammatory markers. Despite her lumbar puncture being a bloody tap, it showed no signs of meningitis, and her urine and blood cultures were both negative. At this point, we had a broad differential. She had a clear pelvic mass, which was most likely a multifibroid uterus. However, this was unlikely to be the cause of her acute deterioration and was more likely a red herring. Her urea, which was not markedly elevated, would not have pointed towards a uremic encephalopathy. A delirium with intra-abdominal sepsis would have explained her elevated CRP and white cell count, but it did not quite explain why she was so peripherally shut down. Malaria was considered given her travel history, but she had no fever and no features of hemolysis. Our final differential was that of an adrenergic crisis secondary to an underlying pheochromocytoma. This would explain the fluctuating blood pressures with almost absent peripheral pulses and significant tachycardia. Imaging confirmed our suspicion, as a large right suprarenal mass arising from the adrenal gland was found with evidence of hemorrhage. In our particular setting, advanced endocrine testing can be delayed for many days, and the importance of clinical suspicion in this setting is paramount, especially as a number of medications can worsen catecholamine surge. Beta blockers given before alpha blockade can precipitate catastrophic hypertension. Metoclopramide, steroids, stimulants, and even morphine may trigger further catecholamine release. Our management focused primarily on careful rehydration, minimizing stimulation, benzodiazepines to reduce anxiety and restlessness, and alpha blockade. A further challenge in our setting was the limited access to IV alpha blockade. We unfortunately only had oral doxazosine available, which made titrating against blood pressure changes very challenging. Meterazine was also not available within our setting. Magnesium sulfate was prescribed to act as a cofactor to COMT to increase catecholamine breakdown. The patient was admitted to ICU, blood pressure stabilized, her delirium and acute kidney injury resolved, and she was discharged in a stable state with a definitive plan to surgically resect the tumor at a later stage. This case highlights the importance of continuously reassessing the differential diagnoses when the clinical picture does not fully align with the presumed diagnosis. In this patient, the fluctuating blood pressures and the profound peripheral vasoconstriction were the key physiological clues that prompted further consideration beyond sepsis. It also emphasizes the importance of clinical reasoning in resource-limited settings, where specialized investigations may not be immediately available, and critical decisions often rely on bedside assessment and pattern recognition. For our team, this was a particularly memorable case, as a pheochromocytoma is rarely managed, let alone diagnosed within the emergency unit. In medicine, we're taught to first consider the most common diagnoses, and rightfully so. However, this case serves as a reminder that while most presentations are forceps, clinicians must remain alert to the occasional zebra hidden within the herd. Thank you so much for your time.
Okay. Next up from Vietnam, we have Dr. Phong An Le.
Good day, professors and doctors. My name is Le Phong An. I'm a final year medical student at the University of Vietnam. Today, I represent my group to present to you a rare mechanical complication of STEMI, right ventricular free wall rupture and cardiac tamponade. Now let's meet our patient. This is a 73-year-old male patient with no known medical history. He came to us with a chief complaint of chest pain. 3 days before the admission, the patient had a chest pain that described as an intermittent left-sided chest pain. Each episode was lasted for less than 30 minutes. 6 hours before the admission, the pain transformed into a persistent chest pain, and now it localized in the substernal area with no radiating site. The VAS score is 7 to 8 out of 10. At this moment, the vital side of this patient were completely stable. The physical examination is remarkable for muffled sound, and the ECG is indicative of inferior STEMI with ST elevation in lead 2, 3 ADS, that mirroring of ST depression in lead 1 and ADL. Shortly after that, the patient's condition deteriorated with profound hypotension, bradycardia, and respiratory failure. At this stage, we approached the patient with ABCD sequence. We support the breathing with endotracheal intubation and the circulation with high-dose noradrenaline, dobutamine, and adrenaline. And then we perform immediate bedside focus and do ABG and other necessary lab tests. We can see here that the patient is in severe metabolic acidosis. The focus result showed a large hemopericardial causing cardiac tamponade, and this is an evidence of obstructive shock. So this patient is underwent an emergent pericardial drainage. At this point, there are two clinical considerations have to be made. The first one is mechanical complication of STEMI, and the second one is an acute aortic dissection. The reason why we have to think of these two, because these two have quite similar clinical presentation. And the treatment after the cardiovascular surgery of these two is completely different, especially the use of antiplatelet therapy and the use of anticoagulation. So we decide to order 3 imaging. The first one is repeat echocardiography, and the second one is the percutaneous coronary intervention. And the last one, if the condition of the patient is able to do, we can proceed. We can order the CT scan with contrast of the thoracic and abdomen area. This is the result of this patient. The PCI revealed a complete occlusion of 9 RCI section 2, and the echocardiography revealed a right ventricular wall thickness. And luckily that the patient's condition allow us to perform a CT scan, and it showed no sign of aortic dissection. That's why the confirmatory diagnosis is right ventricular three-wall rupture, secondary to inferior STEMI. The patient then underwent surgical intervention, and he then moved to ICU, and his condition gradually improved, and he went home after all. So why we present this case to you is because the mechanical complication of acute MI is exceptionally rare in the patient area. That's why physicians may got some hesitate when first encountered. And the second one is the right ventricular three-wall rupture is exceptionally uncommon, and it might need 2 types of shock. The first one is cardiogenic shock, and the second one is the obstructive shock. That's why we want you to emphasize that not all shock in STEMI is purely cardiogenic shock. So this is our take-home message, and this is our reference. So thank you so much for listening to us. If you have any questions, please let us know via email. We're happy to answer all of your questions. Thank you so much.
Thank you. The next case we have is Dr. Barbusa from South Africa.
Good afternoon. My name is Andrea Barbosa, and I'm a medical officer that works across emergency units in South Africa. My case today is about how a massive multifibroid uterus led to acute aortic compression and bilateral lower limb ischemia. This particular case was encountered during my time at Mitchell's Plain Hospital. Firstly, thank you to my mentor, Dr. Candice van Kollensbruggen, as well as the family of the patient who has granted me consent to present today. So we have a 52-year-old female, hypertensive, dyslipidemia, asthmatic, known with ischemic heart disease, presenting with a 1-week history of worsening lower abdominal pain and back pain, with progressive bilateral lower limb weakness, as well, and paresthesia, now unable to mobilize. She's had multiple clinic visits prior to this and was repeatedly discharged with analgesia. Her airway is patent, GCS 15 out of 15 with a normal respiratory exam, blood pressure 168/81, heart rate 66. She had a distended abdomen with a palpable, non-pulsatile mass, cyanotic toes with cold, mottled and pale lower limbs, with absent peripheral pulses bilaterally. She had absent sensation of her lower limbs, with a weakness 0 out of 5 of the distal muscle groups in their legs, with some proximal muscle groups sparing. On investigations, she was assessed as having advanced acute limb ischemia, Rutherford class 3, so with complete motor and sensory loss. On point of care ultrasound, we did see a large heterogeneous pelvic mass with no visible flow and color Doppler. An urgent CT angiogram was done, which showed a massive myomatous uterus compressing the distal abdominal aorta. With complete arterial cutoff in the right lower limb, with limited distal reconstitution in the left lower limb. So this video is just to illustrate the visible aorta that is starting to be compressed at the level of the right kidney. And as you can see, there is very little blood flow also going into the lower limbs. So in terms of management, urgent surgical consult was done, but the condition was deemed non-salvageable due to advanced ischemia, with a high risk of morbidity and mortality with surgical intervention. The patient was transitioned to palliative management and unfortunately died within 24 hours of presentation. So regarding the challenges of this case, even though the patient triage orange, there is an at least 4 to 8 hour waiting time, which allows for condition deterioration. There is overburdened clinics with a high patient volume, and which often results in poor application of basic clinical skills that may delay diagnosis and result in worsening severity. There are limited resources, such as point of care bloods, ultrasounds, and other forms of imaging. The clinicians themselves may have their own anchor bias and premature closure with diagnoses such as chronic back pain. According to the literature, so uterine fibroids are the most common benign pelvic tumors in women, affecting up to 70 to 80% of women by the age of 50. Extrinsic compression commonly occurs onto adjacent pelvic organs, as well as the venous system, leading to venous thrombosis. But in terms of the current literature on arterial complications, there's only 5 case reports on PubMed search from 1900s to May 2026, with interventions including hysterectomy, vascular stenting, and limb amputations. So the teaching points for this case: a patient who repeatedly presents is a red flag. Get senior input, change your approach to the patient. Basic clinical skills are vital in the absence of resources such as imaging and can give us important information. Beware your own anchor bias and premature closure on diagnoses such as chronic back pain, especially in emergency medicine with the undifferentiated patient. And lastly, large fibroids are really an emergency medicine issue, but missed opportunities for early clinical assessments and intervention may result in life-threatening aortic compression. Just a thank you to my mentor and teammates and my references. Thank you, everybody.
Okay, next up from Vietnam, we have Dr. Hong Ho Nguyen Huy.
Hello, my name is Hong Nguyen Huy, a diagnostic radiology resident from Vietnam. Today, I will present a case of life-threatening hemoptysis revealing a rupture of the arch with pseudoaneurysm. The key message is that a rheumatic respiratory presentation may occasionally be caused by a catastrophic vascular lesion. I have no prevalent financial relationship to the cause. There was no external funding or social influence of the educational case. All patient identifying information has been removed. The patient was an 81-year-old man who presented with progressive cough for 2 days or 3 days, followed by a large swollen bright blood hemoptysis. He had no chest pain, fever, or dyspnea. His history was notable for thalassemia and chronically low baseline circulating blood pressure. On arrival, he was unstable with blood pressure of 80/53, heart rate of 108, and oxygen saturation 89%. Laboratory tests show hemoglobin of 98 grams per liter, NCV 66.3, mild hyponatremia, and normal renal function and coagulation. In severe hemoptysis like this case, the emergency question is, where is the bleeding source? The source may be bronchial arterial, pulmonary arterial, parenchymal, or airway related, or less commonly systemic arterial and aortic. Although bronchial arteries are the most common source, unstable or atypical hemoptysis should prompt evaluation for rehabilitative cause, including pulmonary artery pseudoaneurysm or rupture aortic pseudoaneurysm. The CTA was the next stage key step because it evaluates the lung volume, airway, pulmonary artery, etc. It also provides an actionable vascular roadmap by identifying vessel, anatomy, landing zones, and maybe identify potential treatment options. For details, the CTA demonstrates a rupture in zone 2 of artery peneural aneurysm arising from the inferior aspect of the aortic arch with a neck of approximately 9 to 10 millimeters, and there was a large superior mediastinal hematoma surrounding the posterior aneurysm, expanding and compressing the left upper lobe. The CTA also saw the extensive hemorrhage, pulmonary consolidation involving most of left lung and a part of right lower lobe with multiple blood clots in the bronchial tree. The proposed mechanism is direct rupture and erosion into the adjacent lung. The posterior aneurysm arose from the inferior aortic arch. A rupture produced a superior mediastinal hematoma which extended into the adjacent auriculum. The blood then entered into the alveoli and bronchial tree, forming airway clot and causing massive embolism. So the symptom was pulmonary, but the source were aortic. And after the CTA confirmed a rupture of posterior aneurysm, the management shifted immediately to an aortic emergency pathway. Because the lesions were close to the supra-aortic bridge, the treatment required a hybrid strategy. We have a right common carotid to left common carotid icon, a taper with standard placement, and a key standing of the brachiocephalus trunk. After the procedure, the patient was admitted to intensive care unit for post-operative monitoring and supportive care. His clinical condition subsequently remained stable. So there are 3 teaching points I want to bring in for this case. First, do not anchor to bronchial arterial bleeding. Second, absence of chest pain does not exclude aortic catastrophe. And the third, CTA is both diagnostic and procedural. It localize the bleeding source and provide a roadmap for embolization, like TIVA, surgery, or hybrid repair. And this preference was used to build the diagnostic framework and management discussion for this case. Thank you for listening.
Thank you. Next, I want to introduce the case by Dr. Lisk from South Africa.
My name is Dr. Lisk, and I'm an emergency medicine registrar at the University of Victoria. My mentor is Dr. Gimali, who is our head of our clinical units of the emergency department at California Tertiary Hospital. My case is an iatrogenic cotrimoxazole overdose, a preventable fatality in a newly diagnosed HIV patient. I have no disclosures, conflicts of interest, and relevant consent was obtained. 63-year-old female, previously independent, newly diagnosed HIV at the local clinic. She was initiated on TLD, INH, and cotrimoxazole prophylaxis. The dispensing error. She was prescribed Bactrim, which is cotrimoxazole, 960 milligrams every hour instead of 960 milligrams once daily. Also paracetamol, 1 gram every 3 hours instead of 1 gram 3 times a day. She therefore consumed around 35 grams of cotrimoxazole over 3 days. The paracetamol consumption was unknown. She had 1 day of progressive confusion, general weakness, and intractable vomiting. She represented the clinic, who gave an unspecified injection and discharged her home. After continuous deterioration, she presented to our medical unit. On arrival, she had a decreased level of consciousness, tachypnea, with also jaundiced skin and decreased skin tone. There was also noted bilateral subconjunctival hemorrhages, the left periaortic hematoma, and prolonged oozing from benefactor sites. On investigation, the arterial blood gas showed a compensated respiratory alkalosis. She had an AKI evidenced by urea of 19 with creatinine 389 with a hyperkalemia. An infected marker was also measured with ECT of 5.25. Hepatic, she was in acute liver failure with a severe transaminitis, decreased INR, and also hyperammonemia. She also had elevated paracetamol levels. Hematology, she had a bicytopenia with also reduced reticulocyte production index, which suggests bone marrow suppression. Differential was a drug-induced multi-organ dysfunction syndrome, was number 1. This was due to the massive cotrimoxazole ingestion and the supertherapeutic paracetamol. The toxicity of cotrimoxazole causing bone marrow suppression, AKI, and also acute liver failure. Paracetamol toxicity, because of NAPI accumulation, also causes central lobular hepatic necrosis. This is worsened by renal failure. Augmented hepatic toxicity synergy with the cotrimoxazole can make this toxicity much worse. Also considered was sepsis, intracranial pathology, and systemic inflammatory response syndrome. Emergency management, patient's airway was taken over and she was intubated and put on mechanical ventilation. IV resuscitation was started and correction of the hyperkalemia, and she was given antibiotics to cover for potential sepsis. Renal replacement was indicated. Unfortunately, there were no ICU beds available locally or in region, and we could not offer a renal replacement therapy. Toxin-specific treatment, she was given N-acetylcysteine after consultation with our poison center, and there was no specific antidote for cotrimoxazole. And the rest was supported. She was kept in our P1 area. She was given folate supplementation, coagulopathy management. Clinical course. So day 0, she was diagnosed and given the medication. Day 1 to 3, she took all the medication, deteriorated. Initially represented on day 4, and then came to us in the evening of day 4. She was boarded in our unit for 5 days, where she had progressive multi-organ failure and unfortunately demise on day 9, and no renal replacement therapy was available for that stay. This death is preventable. A dispensing error caused the entire cascade, and the case was escalated to the referring clinic for further investigation. Teaching points: medication safety is a patient safety issue. Legibility, dispensing accuracy, and pharmacy medication are critical safety nets. Representation, urgent medication review. Representation shortly after starting new medication should prompt urgent reassessment of all therapies. Resource limitations demand a new approach. When definitive therapies such as renal replacement is recognized but inaccessible, emergency management must extend to harm mitigation, transparent family communication, and active advocacy for systemic change, and most important, quality improvements planning. A problem such as this cannot be put on one person. It is a system that works together. If we can identify flaws in that system, we can figure out areas in which we can improve to prevent the outcome, such as this iatrogenic medication overdose. Thank you.
Okay, and finally, for our last presentation of the morning, we have Dr. Phat Nguyen from Vietnam.
Welcome everyone to our presentation for today. My name is Nguyen Phat, together with Hoàng Phương Man. Welcome to our presentation for today. My name is Nguyen Phat, together with Hoàng Phương Man. I'm from the university. Our mentor is Dr. Nguyễn Quang Huy from the Vietnam Institute of Tropical Medicines. Today we'll present a case titled "A Febrile Stroke Mimic After Floodwater Exposure. Melioidosis Complicated by Cerebrovenous Sinus Thrombosis." This is disclosure. So our patient was a 38-year-old man with type 2 diabetes mellitus. He was a farmer with recent floodwater exposure. 7 days before admissions, he developed a gradual diffuse headache, fever up to 39 degrees Celsius, and nausea. The fever persisted. Then on day 0, he had a generalized seizure lasting 35 minutes with loss of consciousness, prompting emergency evaluations. Upon exam, he was febrile, mostly awake. GST was 15, he was stable. He had asymmetric upper limb weakness, left arm 2/5, right arm 4/5. There were no meningeal signs, no cranial nerve deficits. He has a white-coated tongue. The key unusual finding was soft tender right parietal skull fluid collections. So at this point, the question becomes, is this a CNS infection? Is this a stroke? Is this a stroke mimic, or are these processes connected? We organized the differential into 4 practical ED bucket lists. The first bucket was CNS infections like brain abscess, cerebritis, encephalitis. The second was cerebrovascular emergencies like stroke, CVST, and venous infections. The third was contiguous or local infections like capillary ascensions or septic phlebitis. The fourth was stroke mimics like tumor, DK, HHS. So the initial investigation showed a mixed picture. The CRP was markedly elevated at 105. D-dimer was elevated at 1.504. CSF showed only about 2 cells, mildly elevated protein, normal to high glucose, and a negative bacterial and fungal microscopy. So the CSF did not look like a classic Perelman meningitis. A non-contrast CT showed only a subarachnoid parietal hypodensity with scalp soft tissue swelling. Because the concern persisted, contrast-enhanced MRI was performed. It showed a 15 by 24 millimeter right parietal lesions, hyperintense and flare and DWY, without clear APC reduction. This was in the subacute infarctions. The venous imaging provided the diagnostic pivot. MRI showed complete superior sagittal sinus thrombosis and right parietal cortical vein thrombosis. This changed the case from CNS infections versus arteriosclerotic to CVST with venous infarctions. The treatment course unfolded in stages. During day 1 to 3, priorities were seizure control, empiric antibiotics, and anticoagulations. From days 4 to 11, fever and seizure persisted, and pulmonary findings such as pneumonia. So infectious evaluations and antimicrobial coverage were broadened. On day 12, blood culture became positive for both Holder and pseudomonas. At that point, the diagnosis came together. From days 13 to 26, he improved, he became afebrile, had no further seizure, and continued rehab. The final diagnosis for this patient was superior sagittal sinus and cortical vein thrombosis with right parietal venous infarctions, Burkholderia pseudomonas bacteremia. So there were 3 main teaching points. First, think CVST in septic patients. Fever, headache, seizure, and focal neurologic deficits should prompt evaluations for CVST alongside CNS infections and arterial stroke. Second, CT and lumbar puncture are not enough. We should not end the workup if the clinical syndrome remains concerning. Persistent suspicions should prompt CT or MR immunography. And third, epidemiology drives early diagnosis. In these patients, diabetes and flood water exposure pointed toward melioidosis and justified early communications with microbiology because Burkholderia pseudomonas may be missed if it's not suspected. So the bottom line is persistent fever, seizure, and focal weakness make early CT or MR immunography, especially when diabetes and flood water exposure raise concern for melioidosis. Thank you so much.
Great. Thank you so much all for these wonderful presentations. You've been representing multiple different countries and continents, and we've been learning some really wonderful things. We have a few minute intermission while our judges tabulate, and we're inviting you all to vote for your People's Choice Award. There's a poll available that everyone can select one participant winner based on the criteria we are sharing. And our chat is open. If anyone has any questions or comments for the group, please feel free to share in the chat. Out of curiosity, did people see any cases in these presentations that they would not see in their own clinical settings?
Yeah, if anyone else is having challenges, feel free to message me, Alejo. We're working on getting a QR code that we can actually share with you all, that you can use your phones to vote. But we are receiving your votes. We'll keep the poll open for the next couple of minutes while the judges continue to share what is difficult deliberations. A lot of really, really great cases.
Thank you for your comment, Dr. Musafan. Very insightful about a number of patients in these cases suffering complications due to lack of access and lack of resources. Do you have a question, Dr. Aslam? There's a few hands raised. I'm not sure we can unmute for questions.
Dr. Aslam or Dr. Kwaye, if either of you have a question, I see your hands raised. You can always message one of the panelists and we will verbalize that to everybody if you'd like.
I've unmuted them if.
It looks like they're noting that they're unable to vote.
Is this still through the QR code? If so, feel free to direct message myself or one of the other judges, and we'll add your score to the tally. Apologize for the difficulties.
Oh, they said they can't see Alejo, only panelists.
Yes, sending to the hosts and panelists is acceptable. We'll all see it then. No problem, Dr. Islam. Great for the top. Very close in the scoring for the People's Choice Award. It's a very tight race for the People's Choice Award. So everyone, please get your votes in.
We also have a QR code for the feedback survey, which we'll be showing here shortly in the presentation if you're unable to access the link directly from the chat. So I've just closed the People's Choice Award, so we'll be back with you here shortly and confer with the judges.
Great point, Dr. Leeskit. Thank you for weighing in. It seems like some success in getting resources needed when you are able to share the statistics on what is going on in your hospital, the bad outcomes that could be preventable if you're able to get the resources you need. Thank you for that.
All right, everyone, congratulations. We had so many votes, over 100 plus votes for People's Choice Award. So first, we're going to announce the third place winner. All right, so congratulations to our third place winner, Dr. Frederick Osamoah Batri from Ghana.
Wonderful job.
And then for our second choice, we actually had a tie. So we want to congratulate Dr. Mangani from South Africa and Dr. Nwasu from South Africa. Congratulations. And then for our first place winner, we want to congratulate Dr. Rashid from Pakistan. Congratulations all. And our People's Choice winner would be Dr. Zelunjo from Nigeria. Congratulations, everyone.
Thank you. There's all of our winners up on the screen if anybody missed what we were reading, but congratulations to everybody today. Everyone is a winner for participating and sharing the knowledge. Thank you so much.
And before you leave, we're just going to throw in again that link to our feedback survey, and then we'll also have a QR code that will show up momentarily. If you could please just take a few moments and fill that out, we'd really appreciate that. Thank you, everyone.
All right, everyone. I'm just going to close out our session as well too by saying a huge thank you to you all. This was an incredibly insightful session today. I learned a lot. It's so important, as Dr. Saima Ali said in her keynote, that we talk about a community of practice. We talk about exchange of knowledge rather than transfer, and collaboration being essential, not something that's a luxury. This is how we learn in emergency medicine. This is how we advance our field. And this is how we advocate for our patients and for better outcomes. So thank you also very much. It was a very difficult judging process. And that is why we are electing to give a joint second place. So there will be a joint second place for that. And I just want to congratulate all of our winners and all of our participants today on all of your hard work. Again, a huge thank you to Alejo and the team at the Center for Global Health for collaborating with us on this case competition, as well as our Department of Emergency Medicine here at the University of Pennsylvania in Philadelphia in the United States. Again, thank you all so very much. We hope this was a wonderful time for you. And please give us your feedback so we can continue to improve the session going forward. We hope to have another session, hopefully by the end of the calendar year, in terms of another case competition. So stay tuned for more information about the next one. Again, thank you all so very much. And we hope you have a wonderful rest of your day. Thank you.
Thank you all. we'll keep this QR code for the feedback survey up. Once you've completed that, feel free to drop off. Again, thank you everybody and have a great rest of your day or evening.